Thank you all for having me here, and I'm very pleased to have this opportunity to share with you some works we've done in the lab. I know most of you are coming doing practice, and you already maybe know in patients more than I do of IV vitamin C. What's my point of view is from my angle is from the bench side about the pro-oxidant function of vitamin C. So I put a question here. Is it a promising role in cancer treatment with high dose of vitamin C? Most of you probably already have an answer, and that answer is yes. And we heard from Dr. Paul Saunders that he gives a lot of positive observations clinically about the use of vitamin C. But out there, many people, you know, in more conventional medical society, they still, to them, they're very familiar with the antioxidant function of vitamin C. But to them, the pro-oxidant function is still something need to be scientifically proved. So I will try to talk about the work we've done to look at the scientific basis of the high-dose vitamin C. And I'll begin with this introductional slides of this interesting molecule. So pro-oxidant or antioxidant, it all comes from the chemistry. So this is the structure of vitamin C. It's ionized form here. So whether it's pro-oxidant or antioxidant, it's all based on the function that vitamin C can give out electrons. It gives out 2 electrons step by step. When the first electron is losing, it forms a radical. So it's called ascorbate radical, and the radical can be detected using an electron paramagnetic resonance. And this is a specific spectrum that we can see. So we will use this technique to detect this radical. And then when the second electron is lost, the ascorbate becomes dihydroascorbic acid. And the dihydroascorbic acid has a structure very mimic glucose. And it can actually be taken up by glucose transporter. And then when this is not stable, so these reactions are reversible. It can go back and forth. But when this is not stable and the ring is breaking here, so the ascorbate go down the degradation, and this is no longer reversible anymore. So the function of ascorbate giving out electron is what is considered to be antioxidant. But then it all matters where the electron goes. So actually the electron can be bypassed to reduce ferric, for example. And then the ferrous can pass the electron to molecular oxygen to form superoxide radical. So think about the product, superoxide radical, ascorbic radical. And then the superoxide radical can go on to be dismutated into hydrogen peroxide. They are all pro-oxidant. So that's the angle we're looking at it. So right after vitamin C is discovered in the 1920s, shortly after the discovery that people found, besides the collagen synthesis function of it, it actually have antiviral actions. Also, these are some examples of the old reports that people published of the antiviral function of vitamin C. And then this molecule really got hot in 1970s when Linus Pauling advocates that it's working in cancer patients. Pauling and Cameron did the observational study, retrospective controlled in a lot of cancer patients. Maybe many of you are very familiar with this study. They used 10 grams a day, and they found prolonged survival, improved the life quality, and some Japanese studies published similar result as well. Then in 1980s, and you probably know the history that Mayo Clinic did 2 trials using 10 grams of vitamin C daily in patients, and they found no benefit at all. So from that time, the ascorbic acid was discarded as a treatment modality by conventional medical societies. But people continue to use it. And as many of you already know, that it has some benefit in patient. So you know that the widespread Riordan protocol and the protocols based or related on it is being used in a lot of patients. And also Dr. Ginny Driscoll, who I am working with right now, have this program in integrative medicine in University of Kansas Medical Center, who has a practicing also based on the Riordan IV protocol. So we surveyed the overall use of high-dose vitamin C in ACAM meetings in 2 years. We found that over 10,000 patients per year are using, or at least this number, are using IV ascorbate at the average dose of 28 grams per infusion. And the average treatment they have is 22. So we surveyed the industry sales of this vitamin C vials, and it's more than that. Of course. So what people are using it for, a large percentage is for infection, and then the second largest category is for cancer, and people are using it for all kinds of other indications. And this is the breakdown of the cancer type which people are using. I don't know how well you can see. This is breast cancer and colon cancer, prostate, lymphoma. These are a few major kind of cancers people are using. And basically people are using in many, or almost all kinds of cancers. So the first question we asked is that, since it's so widely used, is there any side effects on it? So we also surveyed, is there any side effect observed in these practitioners? Very minimal comes out, very minimal. So you can see that with the patient number that we can track that the doctor with response of side effect, that only very few out of the total number of patients, you add up all the numbers for the total. So majority of them don't have any side effect, no complaints. So the most reported complaint is fatigue, which if you're thinking it's cancer patient, it's very minor. So we do have renal failure reported of one case here, but that case is described as not confirmed. It's possible, but the patient had partial renal failure before he started IV vitamin C, and then he has cancer metastasis to the kidney also. And then we have another single practitioner reported the mental status change, but that's from only us, the 20 cases are all from a single practitioner, and he has no description of what does that mean. So we can say what could be they're more they're happier, they're or crazier. We don't know. We don't know. So overall, the side effect that but the observation is very, very small. Then we also searched the FDA database for the adverse event report. The database shows some cases there, but also, first of all, a small number. And second of all, we think this is not likely to be caused by vitamin C, because look at the dose that is in these cases. There are no, actually. And there's many confounders of this database. One patient can be reported many times because they don't have the identification. So, and then all the patients have very serious or life-threatening disease before they started the IV vitamin C, and they are simultaneously receiving multiple or many medicines there. And then we also searched literature. We found 187 papers reporting the use of high-dose IV vitamin C, 3 cases in renal failure, and all these patients have pre-existing renal problems. And then a real warning is about the hemolysis, but the 2 cases that reported to have hemolysis, the patient don't have G6PD function. So in that case, we can screen our patient if they have normal G6PD function and they have normal kidney function. It looks like there's very minimal side effects there. So then the next question we ask is it clinically effective? So maybe the best way to answer it is with formal clinical trials again. So they're ongoing, not done yet, with high dose of IV ascorbate. Then there are many case reports show very supportive for this use for benefit in patient. Maybe many of you know much better of those cases than I do. I just give a few examples. This is a paper that Dr. Pandiati, together with Dr. Riordan, Dr. Hofer, and Mark Levin, and using the NCI best case series guidelines, they reported 3 cases. I'm not going into detail of these cases. If you're interested, you can pull up this paper quite easy in the PubMed. If you haven't known it, but I assume most of you already know it. And this is a picture I'd like to show you with Dr. Driscoll's recent patient. This is a newly diagnosed prostate cancer. So this patient is scheduled for surgery, but before surgery, he refused any chemo or radiation or anything. He just go on to very intensive IV vitamin C at very high doses, and he got 23 doses. So you can see this is a PET scan. I don't know how clear it is to you, but right. Okay, so this is before and this is after. So as you are all doctors, I don't need to say any further words about it. And then, how does it work? What's the mechanism? How can those, so why we need to use, why we all continue to see this with high dose of IV vitamin C? So really, we don't understand this for a long time. And then Dr. Mark Levin did this pharmacokinetics study of oral vitamin C versus IV. So he found that with oral doses or under physiological conditions, the concentration in your bloodstream of vitamin C is tightly controlled. There are several mechanisms to control that. So the result he found that is your plasma concentration cannot reach very high with oral dose. You don't observe that much. Second, you have tissue saturation, and then third, your kidney works very potently to get rid of what's extra there in your blood. And then, with a normal diet, or under these doses, your plasma concentration is likely to be around 70 to 80 micromolar of vitamin C. So maybe if you push really hard to several grams and several times a day, you can push it higher, but it's hard to push it very high compared to the IV doses that I'm going to show you. So I just draw it here. It's roughly, the saturation dose is equal 5 servings of fruits and vegetables here. So we go back to look at Linus Pauling's trial and the Mayo Clinic trial. And we found that there's a major difference of the route that they administer this vitamin C. So linazepam used IV for 1 week in these patients and then followed by oral doses of 10 grams a day. But all the Mayo Clinic patients only use oral vitamin C. Could that be the difference? So this is a computer modeled what's possibly could be happening in this patient. The blue line might be in linazepam patient. Look at the y-axis, it's millimolar. So the pink line might be what happened in the Mayo Clinic patients there. So is this real, or this, we found that it is real. That in patients that receive high dose of vitamin C, their plasma ascorbic concentration not only can reach 6 millimolar, they can reach 20 to 30 millimolar. And this is proved by either in Dr. Driscoll's patient or by Dr. Hoffer's former phase 1 clinical trial. And now we think we have a drug here. It's no longer vitamin. It's a pharmacological drug. So this pharmacological drug need to be achieved through IV or IP, parenteral injection. If you eat, you probably cannot reach that concentration. It needs high dose. So I will just call it pharmacological ascorbate, and I will talk about pharmacological ascorbate mainly concern the concentration over 200 micromolar. Then we think, so is that high peak really working on cancer cells? So we cultured multiple cancer cells here, a bunch of them, 48 something. So we treat them with that high concentration, up to 20 millimolar, which is achievable in human. And then we treat them for only 2 hours, because that peak, if you remember Dr. Hoffer's curve, that peak is here for only a couple of hours, and then your kidney bring it down eventually. So we expose these cells to that a serious concentration of ascorbate up to 20 millimolar for 2 hours, and then we wash ascorbate away and wait for the next day to detect the cell survival. So what I'm showing you here is the concentration needed to kill half of the cell. So the lower the bar, the more sensitive the cells are. The higher the bar, the more resistant they are. So you can see that a large number of cancer cells are very sensitive to this treatment, while the 5 normal cells we used, they are not touched by even 20 millimolar of ascorbic acid. So this is to brought to you in detail how the dose response of the cell death is to ascorbate. So this black line is a lymphoma, and the pink line is a normal lymphocyte, and the blue line is normal monocyte. You can see lymphocyte and monocyte is not largely, it's not responsible for ascorbic treatment, while lymphoma cells can be killed by this treatment. And then we go ahead to test this effect in animal. So we injected the animal with cancer cells. We tested 3 kinds of cancers: ovarian, pancreatic, and glioblastoma. And you all know that they are very aggressive and very hard to treat cancers. So we injected them with daily ascorbate, IP, 4 grams per kilogram. That's a high dose. And then we injected the control with saline. Here, the black line with the round dots are the control. This is the tumor growth. This is tumor volume we measured. And this is ascorbic treated. So in all the 3 kinds of cancers, we have significantly inhibited tumor growth with ascorbic treatment. And the bar shows you the final tumor weight at the end of the treatment. They're all significantly reduced. All the tumors are smaller in the treated animals. And especially in the glioblastoma, we found that 30% of the animal have very lasting metastasis all over the belly, all over the body in the control group. But in the group that treated with ascorbate, none of the animal have metastasis there. So if you remember the first chemistry slides I showed you, we're thinking that maybe the electron that ascorbate loses are passed to oxygen to form, ultimately to form hydrogen peroxide to kill the cancer cells. So we're testing adding catalysts. Catalysts specifically destroy hydrogen peroxide. So we add catalysts to the culture media. And we found that with catalysts coexisting with ascorbate, the cells are all protected. So while ascorbate alone almost kill all of them. And then we use another mimetic of catalyst, manganese T-BAP. It does the same job, protect the cell from being killed by ascorbate. So this is, to us, a very direct proof that the mechanism is through hydrogen peroxide formation. Then we were thinking that, is this only an artifact in the Petri dish? Does it really happen in vivo? So we go ahead we repeat the pharmacokinetics in animals. We found that, yes, your high dose of IP ascorbate can bring the ascorbate level either in blood, in normal tissue, and in cancer tissue to very high millimolar range. So first, we can deliver the drug there without problem. And then we found this radical formation. So with that high concentration you achieved in your blood, you have very little radical formation in your blood. But when that high concentration of ascorbate is distributed in your tissue, you have robust radical formation. Here, the blue dots are in normal tissue, the pink dots are in cancer tissues. So both have very high levels of radical formation. And then, again, this is a slide showing you the time course of the radical formation. You can see the radical is formed there, and it's lasting there for at least 3 hours. And then we go ahead to try to make hydrogen peroxide in vivo. This was not an easy job. We probably spent a year to establish more than a year to establish the method there. But then we finally were able to measure it with a synthesized dye that that can catch the hydrogen peroxide when we use microdynamics to draw the extracellular fluid out. So we found that in tumor tissue, pink here, hydrogen peroxide is formed, and it has a higher concentration than in your normal tissue. So we have two factors here. We have slightly higher hydrogen peroxide in tumor, and we have tumors more sensitive to them than normal tissue. So we come up with this conclusion that your high dose of IV vitamin C deliver that drug, that pro-drug, to the tumor tissue. And here, the ascorbate is oxidized, lose an electron, form an ascorbate radical, and then the electron is passed through some metal-centered catalyst to form a superoxide radical, and the superoxide radical dismutated to hydrogen peroxide, and the hydrogen peroxide is the effective molecule to kill the cancer cells. Then the question comes that in the animal study, the ascorbate not totally inhibits the tumor growth. Well, as you know, I don't know any of chemo drugs that totally kills the cancer cells either, but, but in animal trials, people will criticize that. So, and also there's a lot of people have concern about ascorbate antagonized with conventional chemotherapy. So we just, trying to answer this question, we say that, well, not totally inhibited, then let's combine it with chemotherapy. And then if you're concerned with the antagonism, let's test it out. So we first do this combination. We choose gemcitabine and pancreatic cancer cell. Gemcitabine is the first-line chemotherapy drug in pancreatic cancer, but only like 20% of patients respond to this first-line chemotherapy there. It's very sad. So we use either, so there's a lot of there's a lot of gemcitabine-resistant pancreatic cancer cells over there. So we use either the sensitive cell line, which is on the upper panels, and we use a moderately resistant to gemcitabine, and we use a very resistant cell line to gemcitabine. And you can see this blue bar is what gemcitabine is killing cell. The y-axis is cell survival, so it's how much cancer cells is left after the treatment. So we use these doses, and since they are reported sensitive cell line, they respond. And then we respond better with to ascorbate. And then if we add the two drugs together, so it kills more. And here, again, we say it kills more in the second sensitive cancer cell line. And I think most convincing is with the resistant cell there. See this, we increase the dose to very high. This is gemcitabine dose. And then gemcitabine is only killing not that much. And then you add ascorbate to it. Look at the third bar here, the combined bar. Almost wipe them out. And this one, even better. You know, they do not respond to gemcitabine treatment at all, this cell. Right. And then you add ascorbate to it. See the blue bars here. So we did altogether in 8, either resistant or sensitive pancreatic cell lines. This is a figure that is processed by through some statistical mathematical way. So the way to read it is like the x-axis is logarithm of the dose of gemcitabine. The y-axis is the logarithm of the fraction affected versus fraction unaffected. So the red line is the combination of the two of gemcitabine and ascorbate. So I don't know if you can see the red clearly or not. If we can reduce the light, it might be better. Okay, yes, please see it in the monitor if it's more clear. So the thing is that you can see the lines, their interaction with the x-axis. If it's more to the left, means that you need less dose of gemcitabine to achieve the same effect. Less dose of gemcitabine when you add ascorbate to it to achieve the same effect that versus you use gemcitabine alone. So you can see, or these are the red lines. They all shift the gemcitabine dose to the left side when you add ascorbate to it. So this is, I take off some of the data to show you like more not compressed. So this is the gemcitabine sensitive cell. This is the gemcitabine resistant cell, moderately resistant. This is a totally resistant cell line here. And then you have using gemcitabine along the LD50s to the cancer cells, 1, 55, and 100. And then you use ascorbate along LC50. The ascorbate sensitivity is independent of gemcitabine sensitivity here. And then we combine these drugs at this ratio because we use high dose of ascorbate in millimolar. So that's why the combination for the sensitive cell is that high. And then it reduces the LD50 of gemcitabine to this, 0.6, 0.3, and 0.3. And this is how much fold of the reduction in gemcitabine dose that you can have with this different ratio. If you want to reach 50% of effect, 75% of effect, and 90% of effect. Look at it in the gemcitabine resistant cells, because you don't respond to gemcitabine at all when you add ascorbate. You have this huge dose reduction folds for gemcitabine. And then we also did it in ovarian cancer cells, again, combined with carboplanting. So this is the carboplanting effect. Again, the y-axis is how much cell is left, the cell viability after the treatment. And this is ascorbate, and this is combination. In the first cell line, the combination totally wipes out all the cancer cells there. And the second cell line, very much synergy here. And the third cell line, if you notice the carboplanting dose we're using, these cells are carboplanting resistant cells. And this line is just to show you the left shifting of the dose response curve with different combination ratio. So the blue line is using carboplanting alone, and either the other colored lines are adding ascorbate to it at different ratios. They all shift the curve to the left, and as the x-axis is the logarithm, so you can see the fold reduction is great. It's also great here. And to show you more visually here, we use the true tannins model, which is a classic model for drug interaction. So we calculate the combination index. What does that mean? I'll just briefly put it. What does it mean? That it's over 1, you have a cutoff of 1 here. Over 1, it's antagonism. If it's equal to 1, it's additive interaction. And if it's under 1, it's synergistic interaction. We can see that with many of the combinations, you add ascorbate to carboplanting, they are synergistic. And here again, it's the dose reduction index showing you how many folds of reduction in carboplanting dose that you can have when adding ascorbate to achieve a certain effect versus using carboplanting alone. And see, they are either tens or more than 2 is great already. And some of them have more than 10 in tens, and even close to 100 folds of dose reduction there. So these are in cells. And we actually go on to put them in animal to test the animal tumor there too with combination with gemcitabine. So we put pancreatic cancer cells. This left panel is the sensitive cell line to gemcitabine. This is a resistant cell line to gemcitabine. So they are busy slides. Let me walk you through with it. So this line high up here is a control animal, which is treated with normal saline. And this line here is treated with ascorbic acid, high dose IP. So it repeats the result that I showed you with previous slides. And this one is with a gemcitabine dose. This, if you can see it here, there's a yellow line and green line, both here. The yellow line is with a higher gemcitabine dose, because this is a gemcitabine sensitive cell line, so the gemcitabine has very good effect on it. And then the bottom line, blue here, blue-green here, is when ascorbate high dose, when gemcitabine high dose is combined with ascorbate treatment. So it still improves it. And then with the overlap 2 lines here, the yellow is low dose of gemcitabine, and then another line, green here, is the low dose of gemcitabine added, combined with ascorbate. Sorry, the yellow line is high dose of gemcitabine. So you can have gemcitabine 30 milligram per kilo, add ascorbate equals the effect of gemcitabine 60 milligrams per kilo here, even in the gemcitabine sensitive cell lines. And more convincing is in the resistant cell lines. You can see here, this line again is untreated control. And this blue line is gemcitabine low dose, no effect at all. And this yellow line here is gemcitabine high dose, also no effect. And this squared line here is ascorbate alone, well, marginal, because they are very tough cell. And this is the combination, these bottom 2 lines. gemcitabine low dose combined with ascorbate, gemcitabine high dose combined with ascorbate. So if you compare this line to this line here, it has huge benefit to combine them. So far, we don't see any antagonism, at least, to see that. So with that, I can draw the conclusion that the physiological control of vitamin C can be bypassed by IV or IP injection, and the pharmacological concentration achieved there forms radical and hydrogen peroxide. And this pro-oxidant action of ascorbate has promise in cancer treatment, and it has synergistic effect with standard chemotherapeutic drugs. Okay, with that, I'd like to show you some picture of the group that did all this work. This is Dr. Mark Levin's group when I was in his lab. This is Dr. Mark SP, who co-authored our PNAS papers, and Dr. Pandiyati, who did the case report and who also co-authored papers with us. And he's also in Dr. Levin's lab. And this is my new group in Kansas City there. And this is a summer student who did a lot of work with the measurement of hydrogen peroxide and radicals. And Dr. Ginny Driscoll's clinical group there. Okay, with that, thank you all for your attention.